grand rounds, virtually and in person. Thank you for those of you that are here in person. I wanted to acknowledge that we're on the gathered on the traditional and ancestral unceded territory of the Coast Salish people. Today, Grand Rounds is presented by the Division of Gastroenterology. And the title is Update and New GI Clinical Practice Guidelines. We have three presenters, and Dr. Telford is going to start off.
Great, thanks so much, Barry. Hi, everyone on Zoom. I don't know who's there, but hello. So put a timer. Good, so I'm going to start it off, and then Dr. Yvette Leung will be up, and then Dr. Alnoor Ramji speaking. So there's been a number of sort of guidelines that have come out over the last couple of years for some very important GI topics. I was going to speak on the new BC guidelines for colorectal cancer screening and the new guidelines for colonoscopy surveillance, both of which were published last year. And then Dr. Leung, could whoever is there's someone unmuted on the Zoom link. If you could just mute your mic. Thank you. Dr. Leung will speak on guidelines that have come out regarding colonoscopy surveillance in patients with long-standing inflammatory bowel disease. And then Dr. Ramji will talk about screening for hepatocellular cancer. And if there's time, I am going to touch on the new GI guidelines that have come out regarding management of antithrombotics in that periendoscopic period. And if there's not time, then that's what we're going to do for grand rounds in the fall. Great, so just to touch on the BC guidelines. So the BC guidelines are published by GPAC, which is the Guidelines and Protocol Advisory Committee, and that's a joint endeavor with the Doctors of BC and the Ministry of Health. It involves, they produce guidelines for many topics in medicine, and some of you may have been involved in these guidelines in the past. We updated the guidelines in 2022. And involving stakeholders from gastroenterology and general surgery, so people, physicians performing colonoscopy, radiologists given the CT colonography, family medicine, and published two-part guidelines, one for screening average risk individuals that also would touch on individuals with a family history of colorectal cancer, and then the second for colonoscopy surveillance for individuals who have a history of having had a colonoscopy in the past and having had a precancerous polyp removed. So an adenoma or a precancerous serrated lesion removed from the colon. What kind of colonoscopy surveillance do they need? And then also patients who've had a previous history of colorectal cancer that's been resected. What type of surveillance do they need? And I put the URL down at the bottom in case anyone's interested. They have the PDFs that you can download. They have nice algorithms in them and are well referenced. But it's a long URL. You can just Google GPAC guidelines colon screening, and it'll come up. So for the BC guidelines on colon screening, we did an updated review of the literature, and there weren't any changes that were made to these guidelines. So for average risk individuals, the ideal screening strategy is screening those in the age group 50 to 74 with a fecal immunochemical test every 2 years. So that's a fecal occult blood test that detects hemoglobin. And then if that's abnormal, they go on to get a colonoscopy. Where available in the province, it is recommended that these individuals are enrolled in the colon screening program just because of the added, benefits of being in programmatic screening, which has been shown to sort of improve outcomes related to colorectal cancer versus someone who's in sort of more of opportunistic screening, and especially with the number of unattached patients, the movement of primary care, it can be hard for people to keep track of when they're next due for their screening or their surveillance. So these guidelines do align with the Canadian Task Force on Preventive Healthcare guidelines that had come out in 2016. Those guidelines recommended, again, that biennial fecal occult blood test, either a high sensitivity guaiac test or a FIT test, and FIT has really supplanted guaiac in our province, or flexible sigmoidoscopy every 10 years. And again, recognize the benefits of programmatic screening. The Canadian Task Force on Preventative Healthcare held a really high bar as to their level of evidence in recommending screening strategies. So they only included screening strategies that had randomized controlled trial evidence supporting a benefit in colorectal cancer mortality and or a decrease in colorectal cancer incidence in patients who participated in either of those strategies. And so I just wanted to, you'll be familiar certainly with the first two, I think, give you a slide showing what screening strategies have randomized controlled trial evidence, that really high level of evidence. And I think the guaiac tests we're all very familiar with. Those, trials started really back in the 1970s and 80s, and that was our first evidence that screening could decrease colorectal cancer mortality. You'll see I've cited a large review that was in JAMA. And so they pooled the 5 trials, the randomized controlled trials on guaiac FOBT. And so that's why we have the 2 different follow-up periods. But the colorectal cancer mortality was decreased, and it went decreased further with longer periods of follow-up. The incidence, however, did not show significant decrease, so future colorectal cancer incidence. The confidence intervals here cross 1. One of these 5 trials actually did show an incidence decrease at 12 years. The pooled results did not end up showing that. And that was the trial that was done in Minnesota. I think it was published in New England Journal in 2012, the longer follow-up results that showed a decrease in incidence. And so that would show, I think, an 18% decrease in incidence. That trial was a bit different, and they were doing annual FOBTs, and they were using the rehydrated Hemoccult, which I don't think is available. There was a really high false positive rate. These patients had a lot of colonoscopies and adenoma removal, and that's probably why that one trial showed an incidence decrease as opposed to some of the other trials. So not super impressive. So you can decrease after 20 years colorectal cancer mortality by 9% with the guaiac fecal occult blood test. That's not something I get really excited about. The flexible sigmoidoscopy trial, so 4 large randomized trials throughout the world, showed a significant decrease in colorectal cancer incidence and in colorectal cancer mortality at a follow-up period of initially 11 years, and they've had subsequent studies that have looked at more longer follow-up, up to 17 years. And these benefits were really attributed to a decrease in distal and rectal cancers, which makes sense because that's what a flexible sigmoidoscopy is examining. These were, for the most part, one-time flexible sigmoidoscopies, although one of the trials had 2 flexible sigmoidoscopies within that screening age group. And the trials had sort of different thresholds as to when, if something was found at flexible sigmoidoscopy, that patient would then go on and have a colonoscopy. So in some of the studies, if any type of precancerous polyp was found, they go on to a colonoscopy. In other studies, it had to be a higher risk lesion or multiple lesions that were found before that patient would then go on to have a colonoscopy. And then finally, just published, you may have seen it in the New England Journal of Medicine this fall, the first randomized trial evaluating colonoscopy for screening. So this, the Nordic trial, and this was 7 Northern European countries who randomized over 80,000 patients to either be invited to a colonoscopy for screening and then followed subsequently for 10 years, or not invited to screening. So a controlled trial. And the results weren't as expected in that they didn't show the incidence benefit that we expected. There was a significant incidence benefit, but only at 18%, and they didn't show a mortality benefit actually at 10 years. So that was really surprising. These are the intention to treat results. So in the per protocol results, there was a benefit with incidence and mortality, and there was a this hit the lay press, and CNN reported on it and how colonoscopy doesn't work, and the GI societies in the U.S. just mounted this huge response and had all the lay press sort of, redacting that or recanting sort of what they had said. It wasn't good for colon screening. You don't want any test that we feel that works to be debunked in the lay press. And so the issue around this was that they only had 42% participation, which is why the intention to treat analysis didn't really show a benefit versus the per protocol. So that really depends on where you're doing the trial. I think if you did a trial like this in the States, you'd probably get a lot more people coming in and having a colonoscopy. So it's it's challenging to know, but it appears that it works, but probably not the best test to invite a population to screen with. Something non-invasive, we think would work better. And we don't just think it. I mean, the evidence does show that. Any questions at all about the trials? Yeah, Scott.
Jen, I don't remember exactly what these studies, but what was the preparation? Was there a special preparation for those, or did they just do enema, or?
I can't remember off the top of my head. I know that some of them were to the splenic flexure and some of them were just rectum and sigmoid. So there were variations in the protocols for sure, the methods. And I don't recall the preps, whether it was a oral bowel prep or which is better, of course, or a fleet enema. All right. So I think we know colon screening works, in for some strategies, maybe not as well as we'd like. But I think the big question is, we know that FIT is a good test. We don't have randomized controlled data on it, but we, experts have really extrapolated the guaiac FOBT data and said, FIT's very similar, but much better. People participate in it more readily. It's only requires 1 specimen versus 3 with the Hemocult. There's no medication restrictions. There's no dietary restrictions, and it detects more. So we think it's going to work better. So the real question is, does it work better than a colonoscopy would? And so there's a lot of studies underway, 4 randomized trials underway. It takes a long time with colon screening because you really need that 10-year time horizon before you see things. So we hear about these trials and then we have to wait our whole careers before we see the data. So there's 4 underway. 2 have actually published data after their very first round of screening. So again, published in the New England Journal of Medicine after they'd finished accrual and all the patients had their first test in 2012. The Spanish study, ColonPrev, published their results, which you can see here. And essentially, there was a group randomized to FIT every 2 years and a group randomized to having a colonoscopy and then being followed for 10 years. The FIT group would only have a colonoscopy if their FIT was abnormal. So they invited to screen, participation significantly higher in the group invited to screen with FIT, and the colon cancer detection rates were the same. But the chance of finding a high-risk polyp was higher in those patients in the colonoscopy group, which makes sense. So what we're waiting to see is whether those patients in the FIT group who have advanced polyps for sure, but had a negative FIT, whether over time those polyps, they never have a positive FIT and those polyps don't amount to anything, whether they never have a positive FIT and they get colon cancer, or whether at some point they have a positive FIT and that precancerous polyp is picked up. So, they finished accruing in 2012, so we're really expecting that data to come out soon, which will be really exciting. The Swedish study also had published their first round screening results, and they showed similar findings. So same rate of colon cancer detection in the 2 arms, and increased participation with FIT. So the last thing I wanted to talk about with screening is early onset colorectal cancer, because this was something we discussed at length when we were looking at the GPAC guidelines. So as you may be aware, there's an increasing incidence rate of colorectal cancer in adults under 50 years of age. And this had prompted the US Society, the NCCN, the American Cancer Society, all of the GI societies to decrease their recommendations around when to start screening from 50 years to 45 years. And this patient population appears to be a bit different. So they have a higher proportion of rectal cancer and distal colon cancer. They have a higher proportion of patients will have more high-risk histologic features in their cancers, like mucinous or signet cell. They're often symptomatic because they're left-sided, so they present with rectal bleeding or change of bowel habits, and often diagnosed at a later stage. Maybe because of that aggressive subtype, or maybe because they're younger, and so their primary care physicians may not be advancing them to investigations. There's been a lot of interest in whether we can identify those younger adults that are at higher risk. Certainly alcohol consumption in most studies that look at this seems to be linked, and then obesity, sedentary lifestyle, a family history. So there's probably some environmental and lifestyle factors. Generally, is it thought that there is a change in the germline? It's happening too fast for it to be a pathogenic variant that's predisposing. So it's not a hereditary colorectal cancer, but there's still a lot to be understood about it. And so this just gives you an idea. So sorry, these are small, but this is Canadian data, so I want to present it. So this is men on the left, so men 50 years and older. Over time, you can see their colon cancer incidence is decreasing, okay? Screening programs, I think. But men who are younger than 50, the colon cancer rate has been increasing. Similarly for women. On the y-axis, these are a little bit deceiving. These are age-adjusted rates per 100,000. But you can see in the over 50 for the men, they're at 180 per 100,000. The y-axis is different for the younger adults. So here in the men, they're at 12 per 100,000. So still much lower numbers than that older group, but those curves are alarming. And this is American data from SEER. So just to sort of look at the different age groups. So here we have 50 where we start screening the incidence rates from a historical time to a more recent time. In the screening age eligible people, the relative change in the incidence rate, so they're going down. Okay, so, and in the younger adults, they're going up. But look how high that incidence rate changes in young adults in their 20s. Still low absolute numbers, right? But you know, it isn't just that 45 to 50-year-old group that we have to be concerned about. It's going up through all age groups. So it's definitely something we have to keep an eye on. And in terms of, you know, the data, if there's further evidence, we may need to alter our screening guidelines in BC. But right now we didn't. And really because of those low absolute numbers, like how many people you're trying to capture in screening that large group. And why start at 45? Like if you're going to do that, maybe it needs to go younger. And there's still a much higher risk in that older age range, and there are a proportion that aren't being screened. So that resource allocation should probably still go to that higher risk group. Okay, I'm going to just touch on the guidelines for colonoscopy surveillance. So it's been very interesting with the screening programs that are around worldwide because there have been several publications, you know, in the last decade from these large prospective cohorts showing that patients who have precancerous lesions removed from the colon, a lot of them actually don't have a higher risk of future colorectal cancer. And that's in part because our technology has improved such that we're detecting a lot more of these. And I think it's a much more prevalent condition than we had thought, at least back, you know, when I was training. And studies showing that patients who have a low risk precancerous polyp removed at colonoscopy, that their future risk of colorectal cancer is actually now less than the general population and approximates that of someone who had a normal colonoscopy. So I think we need to sort of change our thinking that once we have someone with a precancerous polyp, that they're at high risk for the rest of their lives and need this intensive colonoscopy surveillance. So the guidelines have been updated throughout the world, in the US, the UK, Europe, and Asia. And so we updated ours this spring, and the major changes are around the low risk polyp. So someone who has a high risk polyp, it's still the same. We want to do a colonoscopy in 3 years, a colonoscopy in 5 years, and then we can, you know, take it from there. So a high risk, your risk stratification sort of comes down to the size of the lesion, how many of them you have, and if there's any high risk histologic features. So a centimeter is sort of our magic number. Size number greater than 5. Okay, it used to be greater than or equal to 3. It's now greater than or equal to 5. And then these features are similar. So any adenoma that has high-grade dysplasia, adenoma with villus features, a sessile serrated lesion that has any dysplasia, so it doesn't have to be high-grade. As soon as there's conventional cytologic dysplasia there, then it's considered high risk, or a traditional serrated adenoma. One other change that is made that we are including large hyperplastic polyps in this high-risk category. Now, hyperplastic polyps in general aren't considered to have a high malignant potential. However, there is some data that the mucinous subtype of hyperplastic polyps may be a precursor to sessile serrated lesions. And certainly once they're large, we're treating them as high-risk lesions, in part because there can be challenges with our pathology colleagues not because they're not good at their job, they're excellent, but they're just really challenging polyps to evaluate. And so we worry that these actually are a precancerous lesion. And so we treat them now, the large ones, as high risk. The small ones are still considered to be not to have any malignant potential. And the other major change that was made is that just because you had a low risk precancerous lesion doesn't mean you need colonoscopies for the rest of your life. At some point, we can shift you back to fit. So this is just an algorithm which is available on the GPAC website, looking at low risk findings on your colonoscopy. You can go to colonoscopy in 10 years. And then if that one's fine, you go back to fit. If you have high risk findings, you go to colonoscopy in 3 years. If things are okay after that, you at least get one more colonoscopy at 5 years, and then you can go back to fit if you don't have any further precancerous lesions. This, of course, surveillance is always dependent on having a good colonoscopy, because if the bowel prep isn't good, your colonoscopist, didn't make it all the way to the CChem, if they don't find them, then we don't know about it. So high quality colonoscopy, complete to the CChem, good bowel prep, being done by a colonoscopist who can find the stuff that's there, and that when they find them, they completely resect it. They don't leave a little bit behind that can then grow into cancer later on. And this is a huge target of our QA in the colon screening program, by the way, looking at that adenoma detection rate and supporting our peers to ensure that everyone's performing really high quality colonoscopies. Great. So my take-home points: increasing rates of colorectal cancer in young adults. So I think, from my perspective, when I see a younger adult now with rectal bleeding or change of bowel habits, I do have that in the back of my mind. And I am, I think I have a lower threshold now to doing a flex sig, like just taking a look and making sure that everything's okay. And then I just really want to emphasize that precancerous lesion, when you have a personal history of precancerous lesion, if it's low risk, that doesn't mean that you're necessarily at increased risk of colorectal cancer in the future, and we don't need to do the intensive colonoscopy surveillance. Great, Dr. Leung.
Jen, silly question. Where is the screen from my face? Like, what are you looking at?
I was kind of looking up there.
You're looking up there?
Yeah, I think there's a camera up there.
And how did you check that?
And then you can use your cursor
Just
like
do that?
that.
Okay. Okay.
Well, we can do, you want to do questions now?
Oh, sure. No, stay up here.
So, quick question.
Dr. Casson.
What about alcohol? Because of the new guidelines, the suggested guidelines, with alcohol and related.
See, if we waited till the end, Alnoor, you could have taken that question. Are you asking how much I drink? So yes, alcohol intake does increase your risk of colon cancer. And, the new guidelines that have come out, I would say that there is data showing that any amount of alcohol increases your risk of cancer. So, colon cancer as well as other cancers. So the new guidelines that have come out are, 2 units per week. But, I think any alcohol increases your risk of colon cancer. Yeah, I'm sorry. I'm so sorry. We were all very sad. But, Any other questions? Yes. Yeah.
Thanks for the talk. With regards to hypoplastic lesion that falls under high grade, high risk.
Yeah, the large ones. Yeah.
I might have missed on your slide, but what was the size cutoff?
Greater than or equal to 10 millimeters. Yeah.
So good afternoon, everyone. Sorry, I'm going to get confused about where I should look. So I may just look straight at Dr. Jen Telford, who's always smiling. So I'm Yvette Leung. I'm a gastroenterologist. I'm part of the St. Paul's GI group. And specifically, I have a very focused interest on inflammatory bowel disease. I only have 5 slides. I'm going to make it as clinically relevant as possible. But anytime I have a chance actually to present in front of the general internal medicine residents, I just want to highlight I spent a lot of time along with Dr. Bressler and Dr. Rosenfeld at the IBD Center of BC. It really is a new model of delivering what we think is the care for most chronic conditions should look like, which is multidisciplinary care. I say this because I know some of you guys will rotate through general GI for about 3 to 4 weeks. So please, please, please reach out to one of us, and we'd love for you to spend a half day with us in our IBD center, something we're really proud of. So it was just my little sort of public service announcement. So in the next few slides, I just wanted to give you a very basic but very, I think, clinically relevant overview of IBD-related colon cancer. I remember studying for my exams as a GI fellow, honestly, even doing my IBD fellowship. And for whatever reason, this particular topic was always just very confusing and just, you never knew which guideline to study for. So I'm just going to give you some very basic principles that I think as general internist or whatever subspecialty you wind up in, if you wind up seeing a Crohn's and colitis patient, you don't need to panic and you just have to go back to very basic principles. So similar to what Dr. Telford had said, I mean, colon cancer is a significant problem, obviously, in our general population. And depending on what subgroup of inflammatory bowel disease patient you're talking about, it is a significant problem, but it's not a problem for everybody. So a general principle I like to teach is that don't think of all IBD patients as having a higher risk of colorectal cancer. It really depends on the type of IBD they have, which we'll go into in more detail. In general, if you look at long-term population-based studies, we do know that there is a very, very positive trend in that in general, if you map out sort of publications from different publication cohorts. So for example, publications from the 80s to the 90s, even to the early 2000s, really were showing us that our IBD patients had a higher risk of colorectal cancer. That often would sound very scary when you went to counsel patients, right? Some older publications I remember reading from the 80s was, after 10 years, your risk of colon cancer goes up by 1% every year. That feels like a ticking time bomb. And if you think about our average age patient who's 20, that's really not something, that I want to say to anybody. But the good news is in the last 10 years, population-based data has shown, if you compare it to previous cohorts, that these rates of colorectal cancer are dropping. Having said that, with this more high risk population, they still go up with disease duration. And the number I use is after 20 years of disease duration, your risk is about 5%. Now, it may be that there are still things we can do on an individual basis to lower that risk, okay? So the big take home point is it's a problem. It's hopefully going to become less of a problem, and you don't need to screen everyone. So who should you screen? So the patients you should think about are the ones who have extensive ulcerative colitis or extensive Crohn's colitis. And we'll go on into a little bit more detail. So these are the things I'm thinking about when I get referred a patient. I'm managing their Crohn's, I'm managing colitis, they're happy, everything's in clinical remission, they have normal fecal cal. But these are the things I'm thinking about that will make me want to scope them more often, okay? So the one would be age of onset. And if you look at a good study that controls for age of onset versus disease duration, age of onset in and of itself is still a significant factor that works independently of disease duration. So what I'm saying is if you have a 70-year-old patient in front of you who has disease for 10 years, and they were diagnosed at 65, that person likely still has a lower risk actually of colorectal cancer if you match for age, but someone with disease duration that happened, unfortunately happened pediatric onset. There probably is something about pediatric onset that sort of changes their biology a little bit. Okay, disease extent. The rule of thumb is they have more than 30% of colonic Crohn's disease involved. It becomes hard though, because I'm really lucky. Often I only inherit patients that have been disease remission for a long time. And it's often hard to get that index colonoscopy. So I'll be honest, there's a little bit of art to that. Anyone with extensive pan-ulcer colitis, which means it's beyond the splenic flexure, have a much higher risk than someone with left-sided disease. So disease up to the splenic flexure. And really when someone has only had limited proctitis, I really don't think of them as any different, truthfully, than, for example, the patients Dr. Telford was talking about. Disease duration I've talked about, but one thing that I think is really changing the landscape of how we think of these patients is their disease severity. So what really gets my attention isn't what the patient is telling me today. I've been started on a biologic, Dr. Leung. It's been a year. It's great. I'm now doing all the things I've wanted to do, but their disease severity before they ever met me. So I'm asking things like, did you think you had many years, many decades, for example, of uncontrolled disease? And it's not pointing the finger. We know that there was limited therapies to treat uncontrolled disease, really even up to the last 5 years. Because someone, even if they're in front of you feeling well, doing well, if they've had 15 to 20 years of extensive, uncontrolled disease, those are the patients that you're actually going to be worried about that they will have some type of IBD-related neoplasia, dysplasia, okay? So it's not just how they're doing in front of you. Patients that when I scope, there's something again about their colon that shows me this is a colon trying to give me clues that I used to be very inflamed. So again, they could have no ulcers, they could be feeling great, but the colon is giving me clues that I didn't used to look so good. So those are things like a shortened colon. For the GI keeners out there, we always say, a colon that is lack of usual landmarks. They're really easy to get into the CCAM. They're short. So if you're a GI trainee and you got into the CCAM right away, be very careful. This patient used to have that, you see. Inflammatory pseudopolyps, I think those play a part in two things. Inflammatory pseudopolyps are going to make it harder for you to find real polyps that actually have to be resected that have dysplasia. The second issue with inflammatory pseudopolyps is, again, I'm trying to be a detective. I'm trying to figure out their burden of disease before they ever met me. And to me, this is what I tell patients, that inflammatory pseudopolyp, it's kind of like a clue at a crime scene. It's telling me that, your colon used to actually have a significant inflammation. These are the clues. And I think you're someone that I will still scope more frequently. PSC in general is just a completely different topic, completely different lecture, completely different patients. Those patients will be screened yearly, and it doesn't matter to me how well they're doing. Every PSC patient gets screened yearly for colon cancer. And then the additional things that makes you want to pay more attention to their colon are the things that Dr. Telford talked about. So a family history of colon cancer. So a lot of guidelines have been published. This is the most recent one. I don't expect anyone writing their PGY4 internal medicine exams to read this. But having said that, I'm going to put up just 2 photos, not to memorize, but to just to walk you through practically what we're thinking about. So here's a patient that I've decided that needs a surveillance colonoscopy based on disease duration, type of disease, all those good things I talked about. Basically, what we're trying to do at the time of colonoscopy is to identify lesions that we think we can remove endoscopically. It may not be a lesion I will remove, but it will be a lesion that I think can be endoscopically removed by Dr. Telford or Dr. Leung, who are in the audience today. So that gets us away from these old definitions called dysplasia-associated lesion, which were very, very unhelpful. So you just want to know, did you resect the polyp or flat lesion, or did you not? And then the second question is, like Dr. Telford said, then you're trying to figure out what is this patient's future risk of getting more of these lesions? And that plays into all the things I talked about, their clinical factors and how easy it was during a colonoscopy for you to rule out lesions that may have been subtle or flat. The whole concept of this invisible dysplasia, so dysplasia that you somehow missed, you never saw, but because you were taking random biopsies, it's something very hard for me to discuss sort of within the limits of this sort of time frame. But the most important thing you need to remember is if it's endoscopically resected, you're good. If there's something left behind in the colon, please refer on. Please refer to one of us who has perhaps more experience using different techniques to visualize the colon. Okay, so that's the big teaching point. And then depending on what you find, depending on if it's high grade, low grade, whether or not you've completely resected it, whether or not you think that colon is at risk based on those clinical factors, you will then recommend, I'm going to see you every year, I'm going to see you every 3 to 5 years, I'm going to see you every 5 years. So again, it's not to memorize anything, but again, to just really understand it's that really individual patient and what you think you may have left behind, okay? So really, that's what I wanted to say about screening for IBD dysplasia. Again, I don't expect general internists to say these are the guidelines, but we really do appreciate these referrals from you guys because often patients are doing well. And because they're doing well and they're not on medication, no one thinks to look again. So my few take-home points is just remember, it is a problem, depends on the patient, but they don't fit into the general population. Anyone that tells you they had long duration of disease above 10 years, anyone where you get the sense they had colonic disease and you just get the sense they were not well controlled, at least for a period of time, please refer them to us. PSC, again, I think there should just be a PSC like center. These are totally patients that behave very differently. There is something very different from them physiologically. They absolutely need to have colon screening every year. And in general, when I counsel patients on their IBD, I call it the well adult checks. We do talk about colorectal dysplasia screening. So again, I think if you remember those few points, understand what that patient's disease history is like, you'll be in a very good sort of confident mode, unlike me 10 years ago when I used to really panic about these questions. So any questions from the audience or from Zoom, although I don't actually know where I would look on the screen if there was any Zoom questions, so maybe just unmute yourself. All right. And again, reach out to any of us if you're interested in coming by the center. I have the great pleasure then of introducing my colleague, Dr. Alnoor Ramji, who has a very large clinical and research practice in liver and is really one of the leaders, both national and internationally, on hepatology.
Thank you very much. Very kind intro, Yvette. Very nice. I just press go, do I? Perfect. Okay. Liver cancer. So we were supposed to do guidelines on liver cancer, and I gave you my slides a few days ago. And then last night I was thinking, why do we actually have guidelines? So we have guidelines for clinical reasons. I'd say, and they tend to be kind of non-differentiated. We tend to keep them a little bit vague to allow a bit of your own clinical judgment. And then the other part where guidelines is really useful, I think particularly in Canada, is trying to get administrators to buy into the context of what is actually needed. I'm not going to say for best practices, because every generation thinks they have the best practices, but rather good practices, because we may not have really really many ways that the support for these certain guidelines along the way. So I should be saying I'm cheating a little bit because I gave a similar talk, somewhat different to our hepatitis C network yesterday, and they were postgrads. So the idea about one of these talks is to take what you can out of it. The postgrads, we came up with great research questions along the way, because I think there is so much to be done for clinicians to come up with different aspects. But I say, if you're an activist, great, call me afterwards, because there's more stuff we can discuss. And certainly if we want to try and make a move on things, we have to discuss more. So these are my disclosures, mostly in context of clinical trials. So liver cancers and the burden of liver disease. Is there a pointer? Here's a pointer here. Okay, let me just shift to this. You can hear me okay, right? Is that okay? Yeah. So liver cancer is a cause of mortality. When you look at the overall incidence, and this is not Canadian, this is global incidence, okay? Liver cancer fits in down here. So breast cancer, lung cancer, colorectal cancer, prostate cancer, gastric cancer higher than liver cancer. So the incidence is here. But when you look at mortality related to liver cancer, 8.3%. Third to really colon and lung cancer. And there's this huge discrepancy. There's no question about that. What do some of these other processes have in common? As Jen said, look, you've got a screening program. So think about my talk with the context of a lack of a screening program. I'll give you guidelines, but not a program to say this is where you put patients in, this is where you can take them out, and this makes a difference, because we don't have that. So one of the things we are sorely lacking, truthfully in Canada and many places, is a screening program. When you look at the worldwide burden of liver cancer, there's obviously going to be discrepancies depending on where you are, right? So in Canada, in Vancouver in particular, very multicultural, very multi-ethnic. We are right on the Pacific Rim. So we are not only influenced by what's here, but what comes here as well. So you must think about newcomers. And this whole new concept, which I'm trying to work towards, is barriers of care, trying to reduce barriers of care, thinking about linkage of care of patients, which we again lack. So that's Canada, right? Low incidence. And then when you look at other regions, particularly Pacific Rim, you see this high incidence, and that goes along with the mortality aspect. There's also this signal of a genetic disposition towards HCC. So you've got the genetics, and then you've got to have some environmental aspect. And we understand less, I think, about the genetics than about the environmental aspect, and particularly viral hepatitis as one of those incident aspects which increasing your risk of HCC. So when we think about who actually gets liver cancer and etiologies related to this, you and I will be bombarded over the future in the context of fatty liver disease, because that has substantially increased the need for liver transplants. So when you're looking at causes towards liver transplant secondary to HCC, forget about the liver failure. So this is liver transplant secondary to HCC. Hepatitis C as an etiology has come down, and this is only 2016. The trends continue. I wanted to highlight here alcohol and NASH. So here's NASH, and then here's alcohol. So those are the two bigger causes of HCC leading to liver transplant these days. Oh, am I wrong screening you? I am wrong screening you. I've got two screens. That's Hep C. So Hep C is going down, right? So HCV is going down just because of DAA as a cause of liver transplant secondary to HCC. And then in blue here, or purple here, is the NASH patients, and that's increasing significantly. And alcohol's actually also been increasing. I suspect that's going to be more plateauing, but the HCC and NASH, and if you think about NASH and alcohol, they're kind of friends, because you see that common pathophysiology, that steatosis leading to the oxidative damage as well, right? And the patients tend to be somewhat similar. So this is not surprising. I mean, you guys all know this, who to screen and how often to screen, but we do forget some nuances. So who is at high risk of liver cancer, i.e. who should we be screening? So any patient who has cirrhosis of any etiology at all, needs to get screened. The other part is the amazing aspect about liver disease is we're able to regress fibrosis, which you really can't say in many other places. But even if you regress fibrosis, once you're a cirrhotic, you've somehow got that mutagenesis there, and you're at risk of liver cancer. The risk of liver cancer may go down, but it is still present. So any diagnosis of cirrhosis anytime, you should start screening. Patients with hepatitis B who are non-cirrhotic, which we'll go into a little bit, those patients should be screened for HCC. And then any person who has really advanced decompensated liver disease, not on a transplant list, when you're looking at life expectancy being low, you may not need to screen these persons. This is from the ASLD guidelines, albeit in 2018. It's not too many updates, believe it or not. When you look at those patients who are highest risk of HCC, I have divided it into 3 separate groups. The first one is the ones who are the non-cirrhotic, okay? And when they looked at thresholds at which you should start screening, if the actual incidence was greater than 0.2%, that would allow you to go screening to a non-cirrhotic population. And they've done this by looking at that 50,000 quality, right? You look at the 50,000 cost effectiveness, and then you look at how long persons would be alive for. So if they're going to be alive for greater than 100 days, they'll automatically qualify for screening. So Asian males, age over 40, should get screened. Asian females over the age of 50, any Hep B carrier with a family history of HCC. And this one worries me. A person of African ancestry, when you see them, you should start screening them, okay? I'm not sure there's truly a sub-Saharan aspect, but somebody of African ancestry, they start screening early. We talked about cirrhosis. Any etiology of cirrhosis, and you can see them all there, if they have essentially a risk of greater than 1.5% per year, that's when you're looking at screening. And so they all have that. They're all between the 3 to 5% per year, probably closer to the 3% per year, but they all fulfill that criteria of who should get screened. Then you come to the lower end, and this is the questions we often get. What about the younger hepatitis B patients? What about the non-cirrhotic Hep C patients, like a stage 3 or a NASH? That's a big one, is now really NASH stage 3. Should we be screening? There's not enough data to suggest they should be screened yet. But the other cohorts up there, we should be screening.
How about you just remind the Hep B carrier, what's the serology there?
So it's great. Yes. Thank you, Brian. So I should be not using the word carrier unless written on there. Either you have the disease or you don't. So you'll hear the residents are sick of me saying this, right? You either have it or you don't, because we've given patients a tag of a carrier. It means like a carrying a suitcase. That's ridiculous. Surface antigen positive patients should be screened, period. So SAG positive. No, so if you're core positive, surface antibody positive, SAG negative, you don't need screening. The nuances would be is, let's say you got SAG negative, let's say you're born with the disease, as in a vertical transmission, you have Vietnamese ancestry, and you're SAG positive to SAG negative at the age of 50. So I see you now, you're SAG negative, but you've been SAG positive all your life. Like in my mind, Hep B is a carcinogen. There's no ifs, ands, or what. It's a carcinogen. The only good Hep B should probably be a dead Hep B, right? So if you are SAG positive at any point here, if you've recently seroconverted and there's no data at which timeline, but if you're older, I would screen you. Yeah. Any others before we move on? This is interesting stuff. Okay. So when you're looking at surveillance for HCC, we talked about the hepatitis C patient who's been treated. So if you cure a Hep C patient and they disappear, but they have cirrhosis, they need to be in a surveillance program. We use the word program very lightly, because even though you get regression of fibrosis, I probably will see half a dozen tumors a year now. In my previously treated HCV patients who I cure and you hug and you say bye, but they end up having HCC coming back in the context of a history of cirrhosis. In patients with NAFL and Hep C, we touched on this. If there's not cirrhotic, you don't need to do that. So whenever we think about guidelines, the next part really think about is, can we personalize guidelines? Can we personalize medicine? Because that's where we should be in 2023 and onwards. So in your Hep C cured patient, I don't think there's much context of personalization. The Hep B patient on therapy, again, I'd be more conservative and essentially treat everybody that you survey everybody that do fit in the guidelines. We talk a bit about thoughts of chemoprophylaxis in this aspect and other modalities or tools for surveillance per se. So I wanted to just highlight this context about cure in hepatitis C and the decrease of HCC. So cure is associated with significant decrease of HCC in cirrhotic patients treated with DAAs. Y-axis, HCC incidence. On the x-axis, those who are not cured, so no SVR, versus those who are cured at 24 months. And if you look at the hazards ratio, without a doubt, SVR is a signal that if you are not cured, there's a higher risk of HCC. We've given that. But look at the one on the bottom. This is what I wanted to really highlight, varices. So varices gives you a 3.65 hazards ratio of an increased risk of HCC. So beyond the actual disease state, certainly if you've got portal hypertension, these are the patients who you should be spending a little bit more thought and timefulness on to make sure they are being adequately followed, because they are the people who are more likely to get HCC. So even after you're screened and after you're treated, those portal hypertension patients is who you really need to be mindful of. For the residents and for who else can make amazingly big databases, which would be obviously the key to many of these disease states, this is data from the REVEAL study, and this is a Taiwanese cohort. They did a retrospective cohort, and they have over 11,000 patients, and they've published 15, 18 articles, high peer reviewed journals. And what they did in this article was really to look at the risk calculator of HCC in the patients with hepatitis B. And they gave you a 5 or 10-year risk. And you can look at various factors. Males have a higher risk of HCC. If you're older, higher risk. Family history, higher risk. Alcohol intake, higher risk. Higher ALT, higher risk. And higher the DNA, the higher risk. But you can see from this context, you can move away from that just general screening to somehow doing this in the context of specific patients. So this is where your young patient with hepatitis may very well actually attend into screening, though they not always may fit into guidelines. So you really have to try and personalize medicine when you're looking even at screening beyond the guidelines. When we look at hepatitis C again, hepatitis B and liver cancer. So this is, I keep doing this on the wrong screen, HCC incidence in patients treated with long-term entecavir. And it doesn't matter which the antiviral really is, but we know that these nucleoside and nucleotide analogs result in regression of fibrosis, okay? And they looked at the cumulative incidence of HCC on the y-axis, and this is all cirrhotic patients not treated versus patient treated. And you can see the significant difference when you look at risk of HCC in those patients who are not treated. So in many ways, you're using Hep B therapy as chemoprophylaxis in some terms towards HCC. And today it would be unethical to really do a study to follow a patient prospectively because of the risk of HCC in these patients. I thought this may be interesting for the internists. So this is data from just about a month ago. Was it this month? This month. I'm already ahead in March. So this is a data set from Taiwan, and they had like 10,000 Taiwanese patients treated for hepatitis C. And they looked at those who are diabetic, non-diabetic, and those who are on metformin, not metformin. So y-axis, cumulative incidence, and this would be 10%, 20%, etc. Okay. Number of years of follow-up, up to 15-year follow-up. And these are all patients who are cured. So we're not talking about non-cured. These are the low risk, well, theoretically lower risk after you've cured the HCV, right? The non-diabetic patients and the diabetic patients on metformin had a somewhat lower risk than those patients who were still cured, had diabetes, but not on metformin. What we don't know are the signals of, how well the glucose was controlled, how long it was there for, things about NASH. I mean, there's been some other studies looking at diabetes and signals of that when you're looking at Hep B and Hep C. And, you wonder about NASH being there as a kind of another intuitive aspect of HCC development. But certainly here, there's this clear differentiation. I'm not saying metformin should be given to all patients, but certainly it is provocative, and that's what you need. You need provocative questions so we can have these interesting discussions. How do we screen? So ultrasound plus or minus, not ultrasound or not, it's plus or minus. So ultrasound is the baseline, and you should use AFP if you wish to look in the context of screening. One of the other aspects is we've talked about who needs screening. We talked about how to screen, but you also need people speaking the same language when they're reporting and viewing patients on an ultrasound. So there is this LERADS reporting system, which is radiologically driven. It's quite simple, really. LR1, LR2 means probably benign. LR3 means intermediate, which a fair number of patients fall into in the end. And then LR4, 5. So these are the kinds of worry in the context of cancer, right? The reason I put this out there was mostly in the context of thinking about where you're getting your ultrasounds, because often they're not reported in this manner. And there's this mishmash of how people are reporting it. And there's not enough consistency. So before you even have a screening program, like a fit test, and it was this high, low fit and high fit and all that, you have to be able to speak the same language. And you're not even doing that at the stages yet. And there's a bit of a discrepancy in what you get in reports, and you get hypodense and non-dense and all that. That's not how it should be. It should be high risk, low risk. Yeah.
Is that for ultrasound or any
ultrasound? No, ultrasound and other imaging too. Sorry. Yeah. But it should actually, should be starting ultrasound. So recognizing that ultrasound has some limitations when you look at certain habitus in particular, and we're thinking about fatty liver, there's a study done in Texas. Now you'll say, well, Texas is a bit off because our obesity rate in Canada is 23 to 30%. Texas starts at 30%, easily into 45%. So there is a discrepancy there. However, I think it's useful to have it in the center, which has those higher challenge patients. So this is a retrospective data set, 2015, and they had 3 radiologists just purely look at the exam, not in the context of did they miss anything, etc. And they found that 66 thought this was, definitely an adequate exam, likely adequate, but you can see this inadequacy aspect. So there is a context of limitation, potentially due to size as well as air. And if you have inadequate modalities, that's when you really have to think about other modalities. And unfortunately, you're really only left with cross-sectional imaging. You can't do a triphasic CT scan every 6 months on a patient. You're just not doing that, right? So it looks at MR. So there are some patients who do require MR imaging. I have to say, I tend to reserve that for those patients who have a very dense liver on FibroScan. Their FibroScan values like greater than 40, 45. They may have signals, often will have signals of portal hypertension, and they tend to be the ones who are tend to be overweight. So when you look at obesity, it's harder to visualize as well. So those MRI scans tend to be the better shot for some of these patients, and you may end up throwing them intermittently in them, although ideally you're looking at 6 months, but that realistically is not happening. So summary today. HCC burden is increasing and a significant cause of worldwide mortality. Screening surveillance in high-risk patients, which we've talked about. One of the biggest issues we really have, as I alluded to, is the lack of a program. So when we see patients with hepatitis B in particular, with discharging to their family doctor, and we may see them every 2 or 3 years, and the note goes back, please do an ultrasound every 6 months. As you know, family practice is becoming more challenging and you're looking at walking clinics or otherwise. But the expectation is that you're still getting them every 6 months, which I'm not sure is truly occurring. So what we actually need to be able to do is to register everybody who's at risk into a program. And so you have Hep B, you're registered into a program, you get a call back. And that puts on an ultrasound or whichever kind of imaging, as opposed to leaving it to the patient, which often is the case or otherwise, because this is where we're getting miss rates. I didn't share data in this, but this is where we're really going to get miss rates of what's happening, because we unfortunately don't have a definitive program for this. Yeah, go ahead, Jen.
Well, I was just going to say, I think too that, we I think a very good service from GI radiology, the gastroenterologist here. I can't get ultrasound every 6 months. My patients, so I could wait.
No longer.
It'd be really interesting to set that up for radiology, even as a pilot, say, like funding here, like set it up where the recalls are.
The recalls are from radiology.
Really good radiologic study. You're getting it done in the same place.
Yeah, it'd be a good quality program. Yeah. And the other part that this really brings up potentially is this inequity lens. which you really have to try and think about, right? Because, if you think about who has hepatitis B, particularly, I'm not going to say North America, Canada, when you're looking at Pacific Rim, is going to be newcomers. And they cannot often advocate, or not often are they advocating for themselves. And then you got this, I think, a lack of linkage, and persons are much more easily lost. So it really puts on the lens of trying to have some equity. Again, it should just include ultrasounds as opposed to AFP. And then I think there's certainly much that will be done towards the personalization. I didn't talk about this, but I was meeting on Friday looking at proteomics and metabolomics in liver disease. But if you think about HCC, that's where this future is really going to be, as opposed to purely imaging, right? You should be able to do this in blood work or urine tests, and much more easily get a definition who's at increased risk and who's not. And perhaps that will be one of the steps towards HCC surveillance. Okay, perfect. Thank you very much. And Jen is back. Any more questions? And we had some discussion on there.
The sensitivity and specificity.
So it misses, I don't, it misses 30% of lesions to begin with. And then you can have these AFBs, which are riding in the 14 or 20 range. And what you're doing is you're causing worry to the patient and sleepless nights, and you're giving them CT scans and MRIs when they don't really need a CT scan. The other part is that if you've got an inflammatory component, which you see more so in Hep B, the AFP rate goes up. So it's not a very good test. So
in a subpopulation, you apply that to all of your patients?
It's an interesting thought to apply to the higher risk population per se, who don't have as much inflammatory disease. So the ones who are cured, because in the advanced cirrhotic, they tend to be less inflammatory. So you could do it in that population. I haven't. I just don't use the AFP because of that variation.
So I did in the patients with hemochromatosis, but I found that for the most part it was very helpful.
In screening. Yeah. Okay. Question. Oh. Very well. Okay. So we can just chat now.
Yeah. So the Hep B, like I have a patient who has a history of Hep B, easily eradicated. I can screen them for the rest of their lives, even in the absence of cirrhosis.
So when you say eradicated, you mean the patient seroconverted?
Yes, thank you, sir.
And I say that because if you think about where we are, right? 95% of acute Hep B's will seroconvert. So you'll be surface antibody positive. If a person gets it young in age, and we say by the age of 0 to 8, because you look at vertical transmission, as well as if you get it before the about age of 8, your risk of you getting chronic Hep B is about 90%. Okay. So if they've got rid of Hep B at the age of 15 and they're surface antibody positive, they're not going to have a risk of liver cancer, right? But if they got rid of it later on in life, that's who I would follow. But if the SAG negative, core antibody positive, surface antibody positive, and they had it ages ago, and I see this in my rheumatology patients and cancer referrals for prophylaxis, you don't need to survey those.
So I don't see like new liver patients. So this is often I'm doing just have to screening on these patients. I'll pick it up. They have no idea when they have it. They didn't have necessarily an acute infection that they can identify. So they seroconverted, but have no idea when they got it or how long they had it for when they seroconverted.
Yeah, you'd still be okay not surveying those. If you have more concrete evidence of when they got it or when they lost it, because the chance of losing Hep B of seroconverting is about 1% per annum, we think at that.
Irrespective of it, they're from some stage.
Yeah, irrespective. But if you get it horizontally, which tends to be more of our, the patient population in Canada, then that's, they get it age 50 and then they lose it straight away, they're unlikely to develop HCC. It's unlikely to get it. Sorry, say that again. We to some degree, right? But I think it kind of depends where they're from as well, ancestry-wise. So that to some degree, so I think that's where the personalized aspect comes out. It helps to differentiate, yeah.
Has there been? It sounds like. Is there anywhere in the world where there are surveillance programs?
So interestingly, Calgary has a surveillance program. However, it's not through entire of Alberta, but they do have some degree of a surveillance program.
When lesions are picked up, is it changing? Like, is the portion of patients that are curative?
Yeah, so it's interesting. The data set I saw was from Taiwan again, and they have a reasonably good follow-up in certain subgroups. You could just imagine a lot of places are HMO driven or otherwise, but Taiwan is very similar to Canada in many ways, right? And when you looked at mortality, it was 30% in those patients who are surveyed versus about 59 or 60% in those who are not. So you're still getting a high mortality, but the context is it's better, right? It is better. Yeah.
So,
Sorry.
I just wanted to add to that. So in Alberta, there is a surveillance program through MIC clinic. The thing is that patients get shuffled there when they meet criteria. They get a Q6 month ultrasound that's followed by MIC. And then if there's a positive lesion, then they automatically get sent for an MRI and then gets a LIRAD score before getting sent back to the herpetologist. But the issue with that then is not only the resource that you have available with the ultrasound, you have to also consider follow up with MRI therapies and CTs, which could add extra barriers. But I'm not really sure what the exact outcome is for the success rate and the treatment success on that.
Yeah, but I think particularly as there's challenges in primary care for follow-up, that's where this becomes even more important, right? Yeah, sorry, Barry.
So there must be multiple studies that show that we talked about incidence, we talked about mortality, but what about the economic component of these programs in terms of not just amount, not just the expenditure, but the impact on healthcare, the impact on the global healthcare, the impact on the people that are being surveyed, all of that. There must be. Is there and just to the point, you refer back to the family doctor, which doesn't exist part of the time anymore. How do you, for that group of patients that many that don't have a family doctor, what do you do in your practice? So two parts of the question.
Okay. So when you're looking at the health economic part, what they've not done is evaluated, as I said, more in the context of therapeutics with HCC, because that is a changing aspect, right? If you're just looking at surveillance and then the diagnosis, that's still cost effective when you're looking at saving lives. But what we don't know is this new therapeutics, so mostly in the oncology realm, right, with the newer agents being used. So that's difficult to differentiate because that's particularly new. So we don't have that context. But if you look purely on the actual process and the patient journey, then you're looking at cost effectiveness.
Jen mentioned that she has trouble getting ultrasounds.
Right.
So not talking about just that population, but the effect on the global healthcare.
Yeah. So okay. So that'd be okay. So that's the overall data set when you look at the cost effectiveness, that this is a worthwhile endeavor. Then you look at the truism, and then my context of the idealism. But the truism is that you can't get ultrasounds every 6 months. So depending where you are, so I will get one ultrasound here and one ultrasound out of St. Paul's, because then it actually frees up some resources. Okay, because it's just easier. Going back to the family physicians, it is becoming much more difficult today than it was 3 years ago. So the conversation is different. So if a patient doesn't have a family physician, actually they're stuck with me if they have B. I try and say, you're going to go into a walk-in clinic and try and get them done until I'm satisfied that they're actually getting follow-up. I'll see them every 6. But this is new. This is new of last 1 year. This was not, and to get to us, you need to actually have a referral. What I'm having a bigger issue is my patient on antivirals, because I only see them once a year. They're missing their antiviral dates now because they never had a re-referral. So they're calling the office and trying to get in or not trying to get in because of the lack of primary care in some areas. Okay, wonderful. Well, thank you. Thanks to see you. And thank you to Jen and Yvette.